What is the confidence interval? So what's the meaning of this line we see on the forest plot?
Yeah, a confidence interval is a concept that tries to make a statistical inference about the results in your own analysis into the population that you meant to study. So let me use this to explain that a little bit better. So let's say that a group of authors decided to do a study to test a new drug in patients with diabetes. When they do that, they select a sample of patients with diabetes. They can't test all the patients with diabetes in the world. It's not possible. So if you do a sample of patients with diabetes and you're going to do a study in that sample, you're going to get results in that sample. You may see that drug A looks better than drug B in the sample, or less people died with drug A than drug B, for example. But depending on the sample size and the statistical power of that and the number of events and a number of other things, you're going to be able to make an inference, a statistical inference about the results of that therapy in the actual population that you meant to study. And that's what the confidence interval is. So the confidence interval now tries to extrapolate the results from the sample back to the population. So a 95% confidence interval essentially means the following. Given this sample size and the results that we obtain in this sample, and the number of events that we obtain in the sample, and the statistical parameters that we pre-established, I have 95% confidence that the true measure of association in the population lies within this certain interval. So let's just apply that here to this example. In the meta-analysis here, we found a odds ratio of 1.31. With more bleeding in patients who receive dual antiplatelet therapy. But that result of odds ratio of 1.31 is the result in the sample of 6,500 patients of the meta-analysis. If I want to extrapolate that to the whole population of patients with coronary artery bypass surgery, which is the sample population that I aim to study, then I have to make a statistical inference. And we use the confidence interval for that purpose. In this case, I have 95% confidence that in the population of all patients with coronary artery bypass surgery, I have 95% confidence that the true odds ratio of this comparison lies between 1.02 and 1.68. And that gives me confidence to say that it is statistically significant, that in the population, not in the sample anymore, that in fact there is more bleeding with dual antiplatelet therapy because the confidence interval here is entirely above 1. Sounds good? Does that make sense?
Absolutely, but it could be any of these values. It could be actually 1.02 or 1.68. That's our range of possibilities, so to speak.
That's exactly right. And of course, it's more likely to be in the center, but it could be, it's like a normal distribution. It could be any of the values. I just have 95% confidence that the true value is in that range.
Could I say that the confidence interval is the inverse of the p-value? For example, in this very study, in this very meta-analysis, we have a p-value of 0.03. If I asked you for the confidence interval of 97%, which is the inverse of 3%, 97%, would the confidence interval touch 1? Is that, let's say, the limit of the confidence interval? Could I invert the p-value to find out what's the percentage of chance that value is correct?
That's a good question. I don't have the exact answer for that one. Yeah, it makes total sense when you put it like that, but we'd have to figure out with the math if it actually plays out to be that way. But the p-value itself is a very important diagnostic measure, or it's an important way in which we do statistical inference. Essentially, what the p-value, but it has a different take. It has a different way of looking at it than the confidence interval itself. What the p-value does is it assumes that there is no difference in that outcome between the two groups, and it says In a scenario where there is no difference between both groups, in my example, dual or single antiplatelet therapy, in a scenario where there is no difference between both groups, what is the likelihood of finding such extreme results by chance alone in this sample, if there is no difference between groups in the population? And in this case, as you mentioned, it was 0.03. So that's a low number. So that means it would be very unlikely. It's actually 3% likely. 0.03 means 3%. It's very unlikely that we would find results this extreme in the sample if there was no difference between groups in the population. So what we do with that is we reject the null hypothesis that there's no difference between both groups, and we say that, in fact, there is a difference between both groups. In this case, we say that there's a difference, more bleeding in the dual antiplatelet therapy group.
Which means, conversely, that you have a risk of 3% of being wrong and a risk of 97% of being right if you ignore the risk for biases or any technical mistake on your part. If you assume you have no biases or any mathematical errors, mistakes on your study, on your calculus, then you would have a 97% of chance of actually having a result that represents what we would find in the population.
That's perfectly correct. That's a very important point. All of this that we've been talking about has to deal with random error, just things that happen by chance and the random variation that happens when we pick a sample of a given population. If you have biases, which are systematic errors that deviate your results from the actual truth, that's a different story. Then you could be committing biases in many different ways in clinical studies.
Is there a reason why we use p equals 0.05 so often? Is there a reason why we chose this cutoff? And should the cutoff be more strict for more unorthodox treatments? For example, if you have a treatment that poses a greater risk to the patient, should you demand a lower p-value to justify its employment?
Yeah, that's a great question as well. The reason why we use 0.05 is just by convention, is that's the way that medicine has evolved, and it seems like a reasonably low number that we're comfortable accepting things as true or false based on probability. And it's also not a bar that's too hard to get, like a p-value of 0.0001, for example. So that's just by convention. To your other question, whether we should, in certain circumstances, be more rigorous with our p-values, accepting only smaller numbers for therapies that may be toxic, for example, to really prove that they have a benefit. I think that goes a lot into doctors understanding these concepts on their own and making individual judgments to their own patients and having conversations with patients about this. Of course, that demands a lot of knowledge from doctors to be able to interpret this literature independently. But I think ultimately that is what is expected of a physician, that you're able to make primary conclusions based on the data itself and not sort of like be just guided by the opinions of others.
Okay, thank you. Which I believe brings us to the conclusion that p-value is the chance you are actually wrong, so to speak, mathematically wrong, how likely it is if you arrive at that result purely by chance.
Correct. That is correct. It's the result. It's the likelihood that you got that result by chance alone, or a result more extreme than that.
Oh,
so
okay.
let's say we have a 3% major bleeding in one group and 1% major bleeding in the other group. That's an impressive difference for major bleeding, 3% versus 1%. The p-value of that difference says, well, what's the likelihood that we would get this difference by chance alone, or an even larger difference by chance alone, like 4% versus 0%, something of that nature. That's what a p-value is. With that in mind, I want to invite folks to participate in the Meta-Analysis Academy, where we teach a 10-step method on how you can develop these publications on your own, starting with developing your own idea for research and organizing that idea, testing whether it's a good idea or not.